Good evening, everyone. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation educational series webinar. This evening, we're going to be talking about chronic spontaneous urticaria, expanding the spectrum of type 2 inflammatory diseases. Our moderator this evening is Dr. Leon Kircik, who's the president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, adjunct clinical professor of dermatology at the Indiana University School of Medicine in Indianapolis, and medical director at Physician Skincare, DermResearch, and Skin Sciences in Louisville, Kentucky. Our speaker this evening is Dr. Raj Chovatiya, who is clinical associate professor at the Rosalind Franklin University Chicago Medical School and founder and director of the Center for Medical Dermatology and Immunology Research in Chicago, Illinois. We would like to thank our supporter, Sanofi Regeneron, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit the question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. Within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, if you want to ask questions to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. And I wrote a little note there so you can see exactly where you need to type in your questions. So without further ado, I will pass the floor virtually to Dr. Kircik.
Thank you, Roxanne, and good evening, everyone, and thank you for joining us. Let's see if... Thank you, Roxanne. Good evening, everyone. Thank you for joining us for another session of International Dermatology Education Foundation. As you know, IDEF is a nonprofit organization where our principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. Since the pandemic, we have been serving our audience not only in US, but as well as in Canada, South America, Europe, as well as Southeast Asia. As you can see here, a couple of the examples of what we have done in the past. Tonight, by the way, please follow us at LinkedIn, Facebook, as well as Instagram. Tonight, we are very lucky to have Dr. Raj Chovatiya, one of the rising stars in dermatology. He is a clinical associate professor at Rosalind Franklin University Chicago Medical School, as well as the founder and director for Center for Medical Dermatology and Immunology Research in Chicago, Illinois, and a good friend of mine. He's gonna be discussing tonight chronic spontaneous urticaria. Go ahead, Raj.
Get myself muted. Perfect. Thank you. And thank you so much for the kind introduction, Leon, and welcome everybody to our lecture here this evening, where we're going to talk all about chronic spontaneous urticaria, ignoring exactly what that slide says for a moment. Okay, perfect. So this is a disease state that you've probably heard a little bit about or a lot about over the past maybe year, maybe several months, and rightfully so. I feel like chronic spontaneous urticaria is having a bit of a moment when it comes to chronic inflammatory diseases in the house of dermatology. And for a long time, even just, I wasn't in training, I guess, all that long ago, but even back in training, I feel like it was one of those disease states where we really said, we don't know that much about it. Patients kind of shuffle around. We're not sure who really has ownership. Maybe it's something that's sort of an allergy thing. Derm is kind of adjunctive, but I think there's really a new thinking behind this disease state, particularly in 2024, where this truly is a disease that falls in our specialty in the house of dermatology. And the theme of our talk tonight is really trying to put maybe a different spin on chronic spontaneous urticaria than you're familiar with, in terms of talking about how it fits in the spectrum of type 2 inflammatory disease, a group of diseases that you've definitely heard something about over the past more than half of a decade, and maybe one that's going to make you understand CSU a little better. So just a quick little boilerplate before we get going. This program is non-promotional. It's sort of very generously sponsored by Sanofi and Regeneron Pharmaceuticals. I'm receiving honorarium for this presentation, and this is not eligible for continuing medical education credits. Nothing that's different than has been previously presented here before. Okay, so our goal here is going to be threefold, and maybe I'll even say fourfold, and I'll add sort of an additional 1, 2, and 3 on here, in the sense that I really want you guys to feel comfortable about CSU as a disease state. And once you feel comfortable, I then want you to maybe get a little uncomfortable and then try to think about exactly how this disease fits in what we know about type 2 inflammation and diseases like atopic dermatitis and prurigo nodularis that you've heard a lot about on the conference scene and publications, in the trade journals, even on this particular platform as well. And what I really want you to do is understand some of the similarities between these disease states, the differences, and then take a deeper dive into the pathophysiology of CSU and understand how this really connects to a lot of principles you already know about from everything you've learned over the past few years related to these more familiar disease states. So when we think about urticaria, we're going to take this back to just basic terms. Urticaria, or quote unquote hives, is typically developed or really characterized by development of wheals, these sort of edematous thin plaques that look raised, oftentimes pinkish in color, you can see right here. And these can occur with or without angioedema. Now, I'm going to sort of grab the bull by its horns, and you're going to hear me say this word angioedema several times during the course of this discussion. And I want you to understand that angioedema is an important word for the urticaria disease state, and it's not a scary word. It literally means swelling around blood vessels. You can think about it in a different way. Urticaria and hives, a bit more shallow, superficial epidermis. Angioedema, a bit more deeper. One of the older terminologies is something like urticaria profunda, or essentially deeper swelling, all right? This is not the same thing as anaphylaxis, but rather a very common feature that you will see in patients that have urticaria, different types of urticaria, particularly chronic urticaria, which we're going to talk about, and can occur as a solo finding all by itself. And we'll talk about that a little more in a moment. When we think about urticarias, they typically occur in two major big subdivisions. We have acute urticarias and we have chronic urticarias. Somebody once upon a time, a long time ago, decided that 6 weeks was the magical deciding line for whether or not you were going to call something acute or chronic. So if you have these symptoms and signs that are lasting for less than 6 weeks, acute urticaria. If they're lasting for longer, that is going to be chronic urticaria. Now, typical urticaria are ones that resolve within 24 hours. Atypical urticaria, which we're not really talking about much today, that have a different cutaneous sensation and sometimes in association with vasculitis and other features, last longer than 24 hours. So by and large, in the chronic urticaria category, which is a pretty common disease state, we think about chronic spontaneous urticaria and chronic inducible or physical urticarias. Put another way, by and large, chronic spontaneous urticaria is exactly as the name says. There's no clear trigger. It happens spontaneously. Whereas in the case of inducible or physical urticarias, this one typically has a known trigger. So if you ever have that patient that talks about every time I apply pressure to the area or friction, every time there's a temperature change, every time there is some type of heat, sweat is another common one as well. Those are all examples of inducible urticaria. Our discussion here is about chronic spontaneous urticaria. And if you were just blindfolded guessing in the dark with a chronic urticaria, odds favor that it will be chronic spontaneous urticaria, which is why it's really important for us to know. So what are some of the characteristics of chronic spontaneous urticaria? Well, the vast majority of patients will have wheals or these hives or these puffy edematous plaque-like lesions. Usually they'll last as short as under an hour up to about 24 hours, but they go away oftentimes as quickly as they came, usually without much evidence of leaving anything behind. If there are lesions that are persistent or they're leaving a lot of secondary change on the skin, this is not something that you're going to really be thinking about in this particular disease state. There's probably something going on. Additionally, I will say that word again, angioedema, all right, an important part of this disease state. About a third of people, maybe even just under half, have accompanying angioedema. What that typically means, just think about it as a deeper form of the same pathophysiology we think about in urticaria. This is going to be usually on the face, the hands, or the feet. Those are the most common locations. It's why the classic picture is, as you see here, around the lips, but it's really acral surfaces, and you can even think of the head as sort of something distal from where the heart is, so it's somewhat acral as well. Now, what are the most common complaints our patients have? Well, itch by and large is one of them. It is another one of our red itchy diseases, and keep that in mind in terms of this theme of type 2 inflammation we're going to draw through here today. Pain and burning can indeed be one that people have. It oftentimes is secondary still to itch, but some folks can really be talking about the dysesthesia that they get from pain, tingling, and burning with this disease. Sleep disturbance, oftentimes mediated in large part by the itch itself, and then psychological impacts too. There's a lot of mental health considerations in this disease state. Patients oftentimes are not sleeping, very itchy, and therefore they're not going to be themselves, very much like when they're not having a Snickers bar in those commercials, right? You're not really yourself when you're really losing focus and you're feeling itchy all the time and you're not sleeping, and depression and anxiety are quite common in this disease state, which maybe shouldn't surprise some of you who've been following a lot of this relationship with diseases like atopic dermatitis and prurigo nodularis. The symptoms of chronic spontaneous urticaria are relapsing and remitting. They can come, they can go. There is a high degree of unpredictability with this disease, and that's oftentimes another big contributor to burden, because you can imagine that if there's a condition that you see that's there, the one thing about it is that it's pretty predictable. It's always going to be there. You don't really know what's coming, what's going in this particular case. So by and large, point prevalence at any given time is maybe about 0.1% of the US population, but sort of total lifetime prevalence is higher than that in terms of people experiencing CSU at some point. Typically, children and adults are going to be affected here. This all age groups, the adult, middle adult range extending into the older edge of that range are going to be the ones that are where you're going to hit pay dirt in terms of the number of patients. There's gender differences that have been shown in some studies, and it's led people to believe maybe there is a relationship to hormonal signaling. This has never been very formally proven, but that's at least the thought behind why some studies suggest that there might be more female predominance. But we also know that for a lot of our epidemiologic studies, there's just better data on females than males based on medical follow-up. In children, gender differences tend to be less pronounced, so this one's a little more balanced overall. Now, I touched on this mental health consideration, and I want to double down on it because if there's anything that makes you want to pause and think about that CSU patient when they come into your office, it's going to be just the oftentimes severe mental burden our patients are going through that really necessitates doing something for them now, as opposed to just trying to kick that can down the road. A lot of chronic urticaria patients have a comorbid psychiatric disorder, so this goes beyond just the symptoms of depression or the symptoms of anxiety, but actual anxiety and depression as diagnosed mental health conditions. There's increased rates of depression and anxiety going almost up to twofold higher in individuals that have CSU versus those that don't. And when you try to do a sort of correlation experiment with Pearson or Spearman, take your pick if you're a statistical nut out there, depression severity tends to correlate quite well with disease severity overall too. And that shouldn't be surprising. The itchier you are, the more unpredictable your symptoms are, the more skin signs you have, typically the more mental health burden you're going to bear. This was a study that was done by a group in Europe that was essentially a global look at an epidemiologic piece, really trying to take a look at data from this particular quality of life questionnaire that's used in urticaria. It's called the Chronic Urticaria Quality of Life Questionnaire. It has different domains, and you can see here that the symptoms of disease are spread out in a lot of different ways, and burden, which goes from 0 to 100 here, 100 being the highest, most burdensome, 0 being no effect whatsoever on quality of life, is spread out amongst itch, not a big surprise, sleep problems, big association with itch, looks and physical appearance, limitations in your life, impact on activities, and even swelling in terms of the eyes and lips. And you'll note that that's there, and that was on here because that is a big part of the angioedema factor. That is a really important part of disease, and I can't stress that enough, and I'm just going to make you guys get comfortable with the terminology. CSU is also associated with quite a bit of work and activity impairment. And you might be thinking, you know, it's a transient disease, comes and goes. It doesn't leave any scars or clear sequela. It really shouldn't be a major impediment on individuals in their day-to-day work. Interesting thought, you would be wrong based on this particular study from the National Health and Wellness Survey, an epidemiologic data set that's been queried a lot for dermatologic diseases, as it does a really good job of capturing outpatient visits. Here they defined estimates of CSU for individuals who were receiving treatment for chronic urticaria at the time, as there wasn't a clear code for CSU in this particular data set. And you can see in these people that were getting treated for chronic urticaria, which were being defined in yellow as proxy CSU cases, there was much higher rates of activity impairment, work impairment, health-related impairment, and even work time missed due to health, compared to the control group that did not have those particular signs and symptoms that were generally matched. Persistence is another part of this disease that feeds into the unpredictability factor and thus feeds a little bit into that quality of life consideration piece, right? So this is a targeted literature review looking at disease duration in chronic spontaneous urticaria. And you can see here that by and large, based on some of these studies, there is a slant. This is a right shifted curve in the sense that a lot folks have maybe a shorter term of disease, maybe more in the 1 to 2 to 3 years range. But you'd be surprised, and I am too, every time I see more data on this, because we always tend to normalize this disease as, don't worry, give it a few months, maybe a year, you'll get through it, it'll be fine. But there are indeed enough reports of patients that are struggling with this for multiple years, even 5 years, as you can see here too. So another key learning to take away from this slide is when you're counseling patients, and I'm cognizant of this too, since I think about some of this data in my visits, don't really try to say, don't worry, it'll be gone pretty quickly as whence it came and you'll be okay, as it might bite you in the butt when they're still coming to see you for a very long time for symptoms that are really not improving even 5 years and beyond. So that was the little primer on chronic spontaneous urticaria. So just to review, 6 weeks and longer, no clear identifiable trigger, you're getting wheals, hives, those swelly, puffy pink areas. You can get angioedema too, which is just a deeper form of that swelling, not the same thing as anaphylaxis, it's just deeper swelling in certain places. And in general, this is going to be itch and lesions that are going on for about 24 hours or less. That is going to be a typical chronic spontaneous urticaria case. So how exactly does everything I just talked about clinically fit into this story maybe I'm trying to tell about type 2 inflammation? Well, let's talk about chronic spontaneous urticaria in the context of 2 disease states that are associated with the type 2 inflammatory pathway, particularly its dysregulation, 2 old friends, atopic dermatitis and prurigo nodularis. And the reason why these are presented on the slide in this way is I want you to think about some of the signs and symptoms and maybe how there are some threads that are carried through across disease state. You can see in the case of atopic dermatitis, when you're making that diagnosis, itch, pruritus is an important part of disease, having eczematous dermatitis of some sort. Then there's other associated signs, but that's really what you need as far as the really simplified AAD criteria. In the case of the core symptoms for diagnosing PN, we know that this is going to be chronic pruritus, so that magical 6 weeks number. There's going to be picking, rubbing, or scratching. That's an important part of the disease. And these really firm pruritic nodular lesions. In the case of CSU, you're going to have your signs going on for 6 weeks or more. This would be wheals or hives with or without angioedema. It's going to occur spontaneously without a clear trigger. And here, again, much like the other disease states, it really is a clinical diagnosis unless there's specific diagnostics needed. But note that even though you're seeing some differences, you are seeing a inflamed rash of some sort in all these diseases. You're also seeing an interesting connective thread of itch. So it does really beg the question, is there something similar going on here, or are these truly all just very different when we get down to the surface? Well, believe it or not, type 2 inflammation actually does underlie some of the common and unique pathophysiology in these disease states. And one important place to begin this discussion is the neuroimmune axis. We know in each one of these diseases, there's actually really important crosstalk between skin cells, between neurons, and between the immune system. And it's really this communication loop that results in neurons being hyperexcitable, causing itch. We also know that neurons themselves in the skin have their own factors that can further activate immune cells. We know that there's communication going on between what's happening with the barrier or deeper down in the case of PN. There's communication happening going on in terms of a lot of the immune cell milieu. We'll talk about some of those like mast cells and basophils, et cetera, in the case of CSU. And this is just an example of some of the things that we think about that underlie pathophysiology that maybe are a little different. So in the case of atopic dermatitis, the barrier and the external environment is an important part of this disease. In the case of prurigo nodularis, fibroblast proliferation, tissue fibrosis, it's a deeper process here compared to that more superficial barrier in atopic dermatitis. There's less barrier issues in chronic spontaneous urticaria. There's a mast cell degranulation, so these cells that are full of all these superactive mediators that just pump out, that cause swelling and can cause itch. And there's a lot of antibody production from B cells too. So all of that sounds really different from one another, but indeed the neuroimmune axis and the central role of certain characteristics characteristic members of the immune system that we affectionately call type 2 inflammation really sit at the center of this nexus. So type 2 inflammation, for those of you guys that maybe need a little bit of a refresher, remember this is one of our paradigms for inflammatory activation. We oftentimes like to characterize immune reactions based on shared and distinct parts of the immune system that are involved. This is usually characterized by key immune cells and key cytokines. It's one way to at least visualize shared modules of activity. We think about type 1 immunity, which was named in order of its discovery. It's not because it's the most important, as being really important for intracellular bacteria or viruses. We think of type 3 immunity on the right-hand side being important for extracellular bacteria and extracellular fungi. And in the case of type 2 immunity, this is unique because this evolved evolutionarily give us control and help over things that are a little more complicated than bacteria and viruses and things that are a little more unpredictable. So you could imagine that the paradigms of type 1 and type 3 make sense when you're targeting small stuff in the cell or out of the cell. But what happens if you have multicellular pathogens like, let's say, helminths or nematodes or arthropods, or unpredictable toxins and venoms and irritants? It's kind of hard to mount a traditional immune response. And so what the body eventually evolved from an immunologic perspective was a number of shared features that were defined by either responses designed to not directly destroy, but essentially try to eliminate. And that would be your itching, your sneezing, your diarrhea, your runny nose, your teary eyes, all to expel as opposed to directly destroy. Or fibrosis as a method to wall things off so they are unable to cause any more damage as a mechanism of tolerance. And this is how cells, which are led by type 2 T helper cells, but include innate lymphoid cells and mast cells, basophils, and eosinophils, orchestrate this particular response. The key cytokines here to remember are things like IL-4, 13, IL-5, and IL-31. And this is where a lot of our disease states that we think about are very common today come from. And so there's this idea of host environment mismatch of maybe there's a reason why there's so many of these diseases, because this arm of immunity evolved for a certain purpose, and that purpose maybe is not necessarily 100% relevant in many places in the day-to-day world. So when we think about type 2 cytokines in these disease states, remember, cytokines themselves are contextually dependent on their activity, so there are unique and shared roles in these different disease states. So IL-4 will start on the left and move our way to the right. We know is an important cytokine for the skewing of naive T cells into Th2 cells. So regular old T helper cells that are undifferentiated, don't have much flavor. It's really important to try to get them, and this is thought to occur centrally in the immune system, into this Th2 profile. We know that additionally, IL-4 helps to drive expression of IL-4 some more, IL-5, IL-13, IL-31 in definitely a very central immune system way. And it's also important for activation of naive B cells. IL-4 and 13 have a lot of shared roles, and a lot of this takes place more peripherally in the immune system. This includes the sensitization of neurons. So IL-4 and 13 are not necessarily direct pruritogens, but they help to sensitize neurons and just lower their threshold for activation. They're also important in mast cell and basophil activation. These are cell types that have a lot of preformed mediators that are just ready to pop out and cause damage along the way. They're important for B cell isotype switching and production of antibodies like IgE and IgG. These cytokines are important in general for antibody production, but they can be responsible for production of these two in particular. Additionally, they're important for expression of adhesion molecules within endothelial cells. These are the so-called VCAM and Icahn, things that are hanging out on the vessels that are really there to get upregulated and cause immune cells to stop, undergo diapedesis, and really squeeze through into the external tissue. Then we see shared roles for things like IL-4, 13, and 31. All of these can work on neurons, and IL-31 is distinct here because it's more of a direct pruritogen, but all three of them can stimulate neuron peptide release from neurons. So cutaneous nerves can produce many of their own factors to drive inflammation peripherally. Finally, in the case of IL-5 and that whole family, all of these together can work for immune cell activation and recruitment to the actual skin tissue itself. All right, so I know that was a lot of immunology alphabet soup. Let's kind of take it to the actual disease state, and I'm going to try to connect clinical presentation and clinical features to what's happening with these cells and cytokines to have this make a little more sense before we really double and triple down on CSU. So with atopic dermatitis, it should be of no major surprise. Impetiginization, flexural AD, post-inflammatory pigment alteration. This is what we know and expect with atopic dermatitis. And clinically, itch, skin lesions, increased risk of skin infections are all important part of this process. But what's happening when you pop open the hood? You can see here that there is barrier dysfunction occurring simultaneously with immune dysregulation. It's that whole chicken or egg question we used to ask with atopic dermatitis quite a bit, but we realized this whole inside out, outside in debate was really silly. And it just came down to the fact that it was all happening everywhere all at once. And so you can see here in general, a variety of environmental factors can activate early elements of the immune system, causing alarmin production, activation of innate lymphoid cells, skewing and activation of Th2 cells centrally, and then production of cytokines like IL-4, 13, and 31, which can then drive changes on neurons. It can drive itch and the itch scratch response. IL-4 in particular can drive increased production of vesicular cellular adhesion molecules as well that are going to promote the infiltration of more cells too. But what about in the case of PN? PN's a little different in the sense that we're not now thinking about the barrier quite as much, but there's a lot of activity happening deeper. So we know that PN lesions are oftentimes these very thick, fibrotic, heavily lichenified nodules, papules, and plaques on the arms and legs. And we know that clinically they can present in certain areas better than others based on how much you have the ability to rub, pick, and scratch. Clinically, intense itch and skin lesions are an important part of this disease. What's going on when we think about the pathophysiology? This is a very, very centrally neuroimmune disease, meaning that you're having a lot of production of a variety of cytokines and other soluble molecules binding to neurons, driving itch. The neurons themselves are producing a variety of neuropeptides that are acting back on the immune cells. These factors are also acting on cells in the deeper part of the skin, like fibroblasts, which are driving more of this fibrotic program and scarring and fibroblast formation and extracellular matrix deposition. So there's a dysregulation in type 2 immunity here, which is less about the external topmost barrier, but really more in terms of the deeper part of the skin itself, which gives rise to some of the different clinical features we think about with disease. So in these two examples, it should hopefully be clear of how two very different looking disease states, and sometimes can have overlap, actually are caused by some of the similar immune aberrations. Now, despite some of these differences in presentation, symptomology is quite similar, and a lot of this has to do with the centrality of the neuroimmune axis in these diseases. So you can see itch and even skin pain, and there's other symptoms too that you could put there that maybe are not as commonly reported, but patients do talk about. And this is really the shared feature between all these disease states, where seemingly you can see how, all right, there's a rash of some sort, but the actual cutaneous changes do seem a little bit different from one another. But the active inflammation in these lesions plus the itch is really what puts them all in the house of the type 2 inflammatory dysregulation disease. And maybe one day we're just going to call this dysregulated type 2 inflammation disease, because there's a lot more disease states that are showing elements of dysregulation of type 2 immunity. So itch is a major burden in all of these disease states, and I probably don't need to tell you that with atopic dermatitis or prurigo nodularis, in part because you've heard a lot about it, but also I think when you meet one of these patients, you know it. But in chronic spontaneous urticaria, same idea. These patients are incredibly burdened by their itch, and they report a lot of quality life burden related to the itch that they're experiencing. What exactly is happening at the neuronal level? I touched on this verbally, but this is more of a pictorial representation of what we know is happening. You have a number of immune cells that are producing cytokines like IL-4, IL-13, IL-31, all of our old friends, and these are working together to sensitize and activate neurons, which is one reason why this, again, neuroimmune, that's how you think about these two things together, axis, is hanging out in all of these different disease states. So when we think about expanding this a little more broadly, again, you have your immune cells on the left, you have your neuron on the right. There is actually this loop ongoing at all times. Inflammatory mediators like 4, 13, 31 binding directly to neurons, causing stimulation or sensitization, which are then causing further production of neuropeptides, small active signaling molecules that are neuron specific that act on both different types of skin cells as well as immune cells to create this feedback loop. And this is actually not only an important part of AD and PN, which I feel like you've been hearing about for the last few years, but this is actually ongoing in the case of CSU too at a molecular level. Now, you may be asking, Raj, I thought that I treat a lot of urticaria with antihistamines. I thought histamine is really important to this. Are you trying to tell me that histamine has nothing to do with this? Well, itch is mediated by multiple pathways, and it is very simplistic maybe to do it this way, but this is kind of how I'd say that maybe our biology of itch understanding involved. We can grossly divide our neuronal fibers up into ones that are histamine dependent and histamine independent. So histamine dependent fibers are ones that are activated by histamine, and so we know that's the reason why antihistamines will work for some disease states, including in the case of some cases of urticaria, but there's also histamine independent pathways of itch. So these are ones that utilize cytokines, peptides, other mediators, small lipids, MRGPR agonists, proteases, opioids to bind different types of receptors that can also activate itch and cause sensitization and stimulation of neurons as well. In the case of CSU, more so than atopic dermatitis and PN, you're actually seeing activity in both of these types of nerve endings. Histamine sensory nerve endings are probably a little less important in the case of AD and PN, as we've learned empirically through data from treatment. They have more importance in a disease state where there's a lot of histamine produced by the important cell, which here is the mast cell. So you can see mast cells and basophils become activated. They produce a whole host of enzymatically active proteins, histamine itself, cytokines, which are going to work through both histaminergic and non-histaminergic nerve endings, which is then going to cause production of a variety of little peptides. You can see two examples here, substance P and vasoactive intestinal peptide, that are going to be working locally. These can actually contribute to feeding back on the activation of mast cells and granulocytes like basophils, causing perpetuation of the disease state. So in the last few slides, what we've gone to is this idea that there's sort of different signs, but similar symptoms to these disease states. When you take a peek at what's happening immunologically, there's similar friends in terms of cytokines and similar cells. But in the case of urticaria, it seems like perhaps we have more nerve endings, both histaminergic, in addition to non-histaminergic being important, as well as mast cells, and in this case, basophils, having a little more focus as your end cell, as opposed to our other disease states. So this is how the unique presentation clinically manifests across these different types of disease. So I'm going to work my way through what you might think seems like a very scary figure that you don't want to look at because there's a lot of sticks and balls and lines going on, but I promise we're going to navigate our way through these quadrants so you feel like a CSU expert in just a couple of minutes. So when thinking about activation of, we'll focus on mast cells, but basophils have some of this overlap too. There's a lot of different ways to activate mast cells. You can see a whole host of receptors. Some are traditionally activated by binding of their ligand. So you can see an IL-4 receptor, for instance. You can see MRGPRX2, which binds MRGPR ligands. You can see c-KIT, that binds stem cell factor. You can also see that there is a C5 receptor, so a complement fragment, right? If you activate complement system, this fragment can bind, and those activate mast cells, which are just primed and ready to release all these histamines and cytokines and proteases and eicosanoids. But there are other ways to activate mast cells too. Mast cells have a whole host of Fc epsilon receptors. These particular receptors are studded with IgE, just waiting to bind something that can cross-link those IgE molecules and cause degranulation. That is one way to activate these cells. Additionally, you could end up with IgG molecules that are self-reactive to your own IgE molecules that are sitting there on the mast cell. These will artificially cross-link them, and this can cause mast cells to explode and degranulate. You can also have autoantibodies that bind directly to these Fc epsilon receptors and then cause them to cross-link and degranulate as well. So in this sense, you can actually have normal signals in your body, antibodies that are binding to other antibodies, antibodies that are binding to your own receptors, and antibodies that are binding to autoallergens or autoantigens of some sort that can cause degranulation. And all of this is probably relevant to the pathophysiology of chronic spontaneous urticaria. So when thinking about the role that type 2 inflammation and particularly type 2 inflammatory cytokines play, we know that the binding of these cytokines to the various immune cells you see here can amplify some of this response, whether you get expansion of Th2 cells, mast cell cytokine production, or migration of cells like eosinophils. I also mentioned before that you can get antibody production from B cells that's driven a lot by IL-4 and 13. And these antibodies, particularly if you're making autoreactive antibodies that come in one of the flavors that I touched on, these can go back and then activate the mast cells. So this is directly driving something that is going to cause further degranulation of your mast cells. We touched a lot on itch and itch sensitization in this neuroimmune loop between the immune cells, neuropeptides, and the nerve terminals themselves. So that's another place where you're seeing these cytokines do their thing. And then in terms of tissue trafficking, we talked about the production of different types of cellular adhesion molecules, oftentimes in the blood vessel, that cause skin honing and cause extravasation. And in a disease state where you have a lot of edema, a lot of swelling, redness, and itch locally, this is an important point, or even sort of just around deeper blood vessels. In the case of angioedema, this is highly relevant. So the big takeaway here is a lot of different ways to activate a mast cell. Some might be more relevant in some cases than others. In the case of CSU, these are all probably playing some degree of a role. And these are all important ways in which type 2 inflammatory cytokines are contributing to this central pathophysiology of the disease state itself. So now, going back to our master slide like I did with AD and PN, clinical presentation, you hopefully have this idea about these wheals and hives and angioedema that we talked about. And on the right-hand side, those are the summary of the clinical features. And when we zoom in on what's going on beneath the skin, we're no longer talking about fibroblasts in the dermis. We're no longer talking about the epidermal surface and the external environment, but now we're really putting the mast cell in central focus and talking about all the different ways that mast cells can be activated, IgE dependent and IgE independent routes. And then these are eventually going to result in vasodilation, vascular permeability, trafficking of immune cells, and this is the downstream consequence that causes these different parts of the clinical presentation that you can see here. So I arrived at the end of our slides. Let me give you our quick summary before I get to what I'm sure is going to be an amazing Q&A. Hopefully in the last, let's say 35, 40 minutes or so, I know it's been a lot of immunology, you can walk away feeling a little more comfortable about chronic spontaneous urticaria, how we define it, what are the terms we use, what is a wheal and a hive, what is angioedema, how all that's relevant to the disease state. Number two, hopefully now you understand a little better about how something like type 2 inflammation and its shared cytokines and shared cells can link together seemingly disparate diseases through modules of similarity like symptoms, itch, and differences in terms of cutaneous signs and symptoms. In the case of CSU, hopefully you feel a little more comfortable about the mast cell, something that we've largely just said, allergy can deal with the mast cell, but really important for us to understand because it is centrally vital to this disease state and can be activated in so many different ways. And there's just going to be so much innovation in terms of figuring out how we can leverage that across so many disease states that it really pays to understand how there's some routes that are IgE dependent, there's some routes that are IgE independent, and this is all probably going on at the same time. Cytokines like IL-4, 13, 5, 31 others are probably all working together in concert in an orchestra to really drive a lot of this pathophysiology. And so really understanding the immunology here, even though it seems like maybe a big leap, is going to really open your mind to thinking about how might be the best way to handle care for a chronic spontaneous urticaria patient. That is my last slide, so I'm happy to welcome the big guy back himself, Leon, for questions if we got him.
I'm gonna be dreaming basophils and mast cells tonight.
I'm glad that my work has paid off here, people. That's good.
Yes, kidding aside, this was very, very, very eye-opening, Raj. I thank you so much. It was one of the best immunology lectures I have listened to. I learned a lot. And yes, you make me feel comfortable about CSU now. So, but, you know, I'm a little bit on the practical side, and we have actually a couple of really practical questions. One is, when the CSU patient come to the office, what kind of workup do you do? What kind of labs do you order? Or do we order anything, or do you need to?
So that's a great question. And this is the same thing I tell any trainee working with me. I don't want to follow up on any labs that I don't need to follow up on, because that's just more work and time away from what I want to be doing. So in the case of CSU, believe it or not, guys, there actually is pretty good recommendations from dermatology and allergy bodies that if you don't have a high index of suspicion for any concurrent comorbidities that are maybe driving in part the pathology, you really don't need to do that much as far as labs go. So some might say the bare minimum would be something like a CBC and a ESR or a CRP. I don't necessarily even order that in somebody that's completely healthy, because it's not going to change my diagnosis. And then there is a relationship between IgE mediated autoimmune type CSU and IgE serum levels, as well as sometimes anti-thyroid peroxidase antibodies. But even then, I would have to have a very high index of suspicion to order it, because it's not really going to change my therapeutic plan for the patient. So the long and short of it is, if you don't feel like you need to order labs, trust your gut. This does not need to be the billion-dollar itch workup where you're ordering flow cytometry and you're ordering SPEP and UPEP. This is not rash or with no rash and just itch. Save the money, save your time, don't order it.
That's great. Thank you. Now, I think you mentioned it a little bit. Angioedema is a little bit of a dirty word, right? And we're always afraid of the anaphylaxis. How does this angioedema that you talk related to CSU different from HAE, from the hereditary angioedema, or should we try to differentiate, or what should we do?
Yeah, that's a great question. So I like that. I'm going to steal that. Angioedema is not a dirty word, guys. So you heard it from Leon. You hear me say it too. All right. So it is an important part of this disease state. Just because its pathology is just nearly identical to what's happening with wheals that we see in urticaria. It's just different levels of the skin. One is deeper around a blood vessel, one is more superficial in the upper dermis to epidermis, and so that's why they present in slightly different ways. That being said, this question always comes up of hereditary angioedema. When I was studying for probably step 1 or something like that, you're supposed to order complement levels, or it's an autoimmune condition. And yeah, there's a few different types of hereditary angioedema, type 1, 2, and 3. So the first couple types are related to deficiency in a certain protease inhibitor for C1q. Type 3 is slightly different. That one is more of a direct mutation. Bottom line, in all of those disease states, they are driven by inappropriate activation of the complement pathway, resulting in elevated levels of bradykinin. This might sound familiar because you guys probably remember that when you use ACE inhibitors in some patients, you can actually end up with elevated levels of bradykinin that cause that cough or even a induced angioedema. These are not common conditions, people, so we're not really going to go chasing around for this type of workup. Typically, if somebody is presenting with the signs and symptoms, as I mentioned, you can go down that CSU tree and feel pretty good about yourself. If there is some index of suspicion about a familial disease that's causing all these other symptoms, then you can consider it. But in the case of CSU, there's actually studies that say maybe even up to 10% of patients present with just angioedema alone, right? So in most cases, you're going to see CSU plus angioedema, but you might see one or the other, and they all generally going to end in the same place for treatment. So practically speaking, it doesn't matter. It's more of an academic debate. And I think that in the cases of true hereditary disease, yes, you can definitely get other friends involved to take care of, but they're not really going to be walking into your office all that often, if ever.
Another question, which is, I think it's also relevant, urticarial vasculitis, right? How do you differentiate that? I actually do a biopsy for that, but do you have any other way?
Yeah, that is one of the times where urticaria and a biopsy go together. So to Leon's point, everybody, if you're just thinking about hives, a biopsy will largely be useless because your pathologist will say it looks like normal skin, or maybe there's a little bit of perivascular derm, maybe some EOs or something, nothing useful. In the case of urticarial vasculitis, let the patient presentation drive some of this. Are these hives lasting for long periods of time, 2 days, 3 days? Is there a lot more predominant burning, pain, stinging, numbness, tingling, as opposed to generally just the itch? Are they involving a lot of the legs and distal extremities where you think about vasculitis being involved? And is there a lot of sequela left behind? Is there bruising? which would imply something is going on with the blood vessels. All of those are reasons that you want to do an H&E and a DIF and really try to rule out any vasculitic process that's going on. And so a biopsy is a smart idea here, but you got to be looking for some of those signs and symptoms, and you'll know it when you see it because it's not going to seem like run-of-the-mill urticaria.
Here's $1 million question. Do you do patch test?
Oh, Lord. No, I do not do patch testing. So, you know, I feel like there's probably patch testers on the line that'll get mad about this. We probably over patch in certain situations, the same way we do over prick testing too on the allergy side. We over test, right? So in general, the main difference between prick testing and patch testing is designed to look at delayed type hypersensitivity reactions, meaning that you're looking at T-cell mediated type 4 hypersensitivity reactions if you use the Jelen-Coombs system. Type 1 hypersensitivity reactions that are more about the allergies we think about with the food and environment and whatnot, that's what you're testing with prick testing. Oftentimes, neither prick testing nor patch testing are going to get you where you want to in the case of CSU. Why? CSU also is known by another name that's fallen out of favor, but it's still true, chronic idiopathic urticaria. The whole point is that we don't know why it's going on, so you're not really going to find anything with those tests.
Yes, I like that better, actually, idiopathic, because that makes me look smarter when I tell the patient. So actually, the next question was, and you sort of answered it, but do you ever refer those patients to allergists?
So, you know, I would say I would be remiss if I didn't say allergy serves a really important role for a lot of our diseases, and urticaria is no different. I would say in the case of chronic spontaneous urticaria, I tend to keep those patients for myself, because whether I am treating with approved therapies, future therapies, off-label therapies, it's all stuff that we're really familiar with in the house of dermatology, and there isn't any additional testing that an allergist is going to provide. Again, there might be an angry allergist on the call that they're not going to provide that you can't already do for the patient. I mentioned that there is limited blood testing that might be useful, and you're more than welcome to do that, but oftentimes the reason to send someone to an allergist is, do you need them to have some type of specialized prick testing, or is there some type of immune tolerance or desensitization? And none of that's going to do anything in this disease state. There's a reason why it's spontaneous and idiopathic.
So I think it's time for us as dermatologists to own CSU, or at least share with the allergist equally, right? I mean, we sort of are so used to refer them to our colleagues, but I think part of that is when we don't have a good treatment option, right? We as physicians, we sort of do that and, okay, go see somebody else, I can't help you. But I think now that we're coming up with some good treatment options, I think it's gonna be easier for us as dermatologists to own CSU and to treat those patients.
And for those of you guys that are following super closely, and Leon would know this because he does so many trials, guys, like urticaria is a crazy place for therapeutic innovation right now. I feel like everybody is trying something. So if you feel like it's been very difficult to treat your urticaria patients, you're entering a time probably the next decade where it's going to become exceedingly easy to treat your urticaria patients.
It will be the next AD.
Right, right.
Okay, one inquiring mind wants to know, and you don't have to answer this, but it says, what does MRGP stand for?
Yeah, it's mass-related G protein couple receptor, so MAS, mass-related G protein couple receptor, and they typically end with like an X or an R or something. It's an interesting class of GPCRs that bind endogenous ligands, but it's not clear which ones, but they seem to have an effect on mast cell degranulation and itch. And so some of the endogenous ligands are certain types of bile acids and other things like that, but it's a receptor that's being looked at from an investigation standpoint for different type 2 inflammatory diseases like CSU, in part because it's on the mast cell itself. I thought Leon was going to catch me and thought I didn't know what it stood for, but I got you there, sir.
That's why I said you can answer it. We can skip this, but I knew that if anybody can, only Dr. Chovatiya can do that. So I thank you so much, and that was really a great session. I do want to thank our supporter tonight, Sanofi Regeneron, and thank you everyone. Now that we are done with the Sanofi Regeneron program, our next program is on Thursday night, December 19th. It's going to be our third webinar this week. with Dr. Andrew Alexis, which is gonna be a CME program. We're gonna discuss a patient journey with atopic dermatitis. I thank you so much, everyone, and have a good evening. Bye-bye.
Everybody, happy holiday. Bye.